Welcome to Santa Barbara Neuroscience Institute's Meet the Doctor webinar. I'm Bob Bahanian, Director of Marketing and Consumerism for Cottage Health. Before we get started, I'd like to review a few housekeeping items to optimize your experience in this webinar. If you have any issues with Zoom, please just send a direct chat to Zoom Help to help resolve them. At the conclusion of this webinar, we'll host a brief questions and answers session. Please use the Q&A button to ask Dr. Moayeri a question. It is now my pleasure to tell you a little bit about Dr. Nicole Moayeri. After her amazing experiences as an undergraduate and medical student at Stanford University and surgical intern at USC, Dr. Moayeri ventured to Massachusetts General Hospital, Boston for neurosurgery residency, followed by an academic appointment at Harvard Medical School. The San Francisco Bay Area pulled her back to California for 20 plus years with the Permanente Medical Group until she found her dream position at Santa Barbara Cottage Hospital, caring for patients with brain tumors and epilepsy. Please join me in welcoming her.
Good afternoon. Thank you so much for joining us today. And I'm looking forward to sharing with you some information that I hope will help your understanding about patients with brain tumors. I know that the people joining us today may be coming because of a personal experience or because of just some curiosity or trying to understand what Cottage Health can offer. And so I hope I can answer those questions. If I don't, please write down your questions and we'll go over them if we have time at the end. So we're going to go over brain tumor types to start with and talk a little bit about brain anatomy. And that will lead into understanding brain symptoms from brain tumors because that's intimately tied into brain anatomy. And then finally, we'll take some time to talk about the novel treatments that are available to us at Cottage. So let's talk a little bit about brain tumors. There's basically two types. The biggest overriding categories are primary and metastatic brain tumors. You may have heard of those. Metastatic brain tumors, of course, come from other parts of the body and spread to the brain. So the most common metastatic brain tumors are lung cancer, breast cancer, and skin or melanoma. And this type of tumor is primarily treated by an oncologist or a radiation oncologist with chemotherapy and radiation. There can be one or multiple. And so it's rare that a neurosurgeon will get involved to remove these. It's primarily if they don't respond to therapies or they're of sufficient size that they need to be removed. But for the purpose of this talk, we're really going to focus on primary brain tumors. And as you can see on this slide, there's a whole lot of different types of primary brain tumors. So let me shed some light on that for you. So basically we have malignant and non-malignant primary brain tumors. And as you can see, you know, the blue slices of the pie here are all the non-malignant brain tumors. And the good news is the vast majority are non-malignant. So chances are if you have a brain tumor, it's going to be a non-malignant tumor. About 70% of them are non-malignant. And the other thing you can see on this slide is that there are, big, large numbers of patients that have non-malignant meningiomas, accounting for almost 40% of all brain tumors. The next largest category are the non-malignant pituitary tumors. And then unfortunately, we have a large slice of the pie, which is due to glioblastoma. So for the purposes of today, this is data that was pulled from the US over the 5 years from 2014 to 2018. So it's very recent data. And it was just reported out at the end of 2021, October 2021. So this is what's going on currently. And I think for the purposes of this talk, we'll just focus on the most common brain tumors, which are meningiomas, pituitary tumors, and glioblastoma, which account for over 70% of all brain tumors. So I wanted to shed a little bit of light on the difference between pediatric and adult brain tumors. As you can see, that as you would imagine, it's much lower incidence in a pediatric population. The scales here are vastly different, 0 to 3 out of 100,000 in the pediatric population as compared to adults, which is 0 to 20. And we're focused primarily on adults today, but the most common pediatric tumor is a pituitary tumor. It starts to increase in the teens. And then that pituitary tumor rate kind of peaks again in the middle ages and then later in life. The glioblastoma peak is much later in life in the 70s. And in fact, meningiomas, we don't even see on this slide because they don't occur in pediatric populations. So the third category of meningiomas is going to peak sometime in the mid 60s to 70s. So that's kind of a broad overview of, the 3 most common brain tumors that occur in adults. The other thing that I think is interesting is to note that of these 3 common tumors, there's a difference based on gender. So in meningiomas and pituitary tumors, they're much more common in females, whereas glioblastoma is more common in males. And it's really important to note that meningiomas do grow during pregnancy. So if someone has a diagnosis of a meningioma and they are getting pregnant or they're thinking of getting pregnant, it's really important to monitor that very closely if they haven't already had treatment for that tumor. So I think, we covered the tumor types and in a broad overview, and I want to give you now a chance to go back to school and learn a little bit of brain anatomy. So we'll spend a little bit of time on my favorite topic in school, which is neuroanatomy. So these tumors can occur as based on the tumor type in different parts of the head and the brain. So meninges are the covering of the brain, and meningiomas arise from those coverings. So they can occur anywhere that those coverings occur. Inside the head, the entire lining of the head is a potential site for meningioma. Pituitary tumors are located where the pituitary gland is located. So these 2 structures really aren't in the brain itself, but they can affect the brain and compress on the brain. And then the other categories you see on this slide are all the different other parts of the brain that can be affected. And it's not like tumors have a particular predilection to one part of the brain or the other. They can occur in the frontal lobes, the temporal lobes, the parietal lobe. And we'll talk a little bit about that neuroanatomy as we go ahead. I really like this slide because it gives you a good idea of how much of our head is filled with fluid. So there's the blue on this slide shows how much cerebrospinal fluid bathes the brain and cushions the brain. So the brain is sitting inside the skull with this fluid around it. And then you have the covering of the brain called the meninges, which is right up against the skull. And that is where the meningiomas do occur, anywhere along the lining of the skull. And they can occur inside the brain where there's further lining adjacent to the brain. And one thing that's really important to note is that these tumors can grow slowly over time and displace the fluid, displace the brain, and really not cause symptoms until they get to a considerable size, and then they cause the symptoms. And it's surprising how big these tumors can get before they actually cause symptoms. And I think it's primarily because of the fluid that's in the brain that gets displaced by these tumors. So these are meningiomas. The other type of tumor, the pituitary tumor, occurs at the base of the skull. So this is a diagram showing you where the pituitary gland sits in the middle of the head, basically. It's surrounded by bone. this little space where it sits. It's called the sella turcica, or the horse's saddle in Latin. So that's the space that protects this important gland. And the way that we approach these tumors is actually through the nose, because it's the least invasive way to get there. And there's another space that's just before the pituitary gland that's called the sphenoid air cell. And that is why this tumor approach, surgical approach, is called transsphenoidal, because we go through the sphenoid. So I'll talk a little bit about the pituitary. It is an operation I love doing. It's one that involves a lot of important structures immediately around it. So this is a diagram showing how the pituitary gland sits in that space, surrounded again by the cerebrospinal fluid, the optic nerves directly above it. And then on either side, as you can see, there's these two round structures, the carotid arteries, and adjacent to those are the cranial nerves on either side in these venous structures called the cavernous sinuses. So you can see there's a lot of important structures around the pituitary gland that have to be protected and preserved. And again, the safest way to get there is through that sphenoid sinus, to open it up and take out a pituitary tumor. So this is a cross section looking up and facing the patient, and this is looking from the side through a cross-sectional view. So now you can also understand how a pituitary tumor growing could have effects on all these adjacent structures. I just want to mention an important fact for the pituitary is that it's actually made up of two parts. It's the anterior and the posterior, the front and the back. The anterior part is a gland, and the posterior part is actually part of the brain. It's connected to the hypothalamus, the inferior part of the brain here. So these two parts of the gland do different things. The anterior part does the hormone secretion, and the posterior part releases these two important molecules, vasopressin and oxytocin, that control water balance in our body and also control milk production. So those are the important anatomic characteristics of the pituitary gland. And as you can imagine, all those important parts of the pituitary have different functions, will also create different types of tumors. So one thing we know is that about half of pituitary tumors don't secrete any hormone at all. And the other half that do are going to secrete specific types of hormone based on the type of cell that's affected. So for example, a prolactin secreting tumor will be called a prolactinoma. The other types are listed here just for your information. These are the most common. There are some rare tumors, TSH secreting tumors, and exceptionally rare is a pituitary carcinoma. So again, vast majority of these are benign. And I just want to kind of introduce you to the whole brain now, which is really what this slide so beautifully demonstrates. It's we talked about the covering of the brain, the meninges, underneath the skull here, where the meningiomas can arise. We talked about the pituitary gland, which sits at the bottom of the brain and is very close to those optic nerves. But now this is the rest of the brain, right? So the frontal lobes are here. This one has been cut to show the fluid chamber in the middle of it, the ventricle. And you can see all the folds of the brain, so-called gyri, the spaces in between those folds called the sulci. So there's, important functions that are encoded in a very regular way throughout our brains. So the motor functions are encoded in this strip that's purple, and it's marked with the locations of those motor functions. So moving your lips, your tongue, your fingers, your elbows, your shoulder, trunk, and then it goes down on the other side into the leg. So it's literally what we call the homunculus. The body is mapped on the surface of the brain. And that motor strip is really an important structure to keep in mind as we talk further about how we treat tumors within the brain itself. Directly behind the motor strip is the sensory strip. And this part of the brain controls sensation in the body. And it's literally mapped the same way that the motor strip is mapped, with the locations corresponding in the sensory area to where the motor area is. So important structures to be aware of, and of course understand speech areas, Broca's areas, Wernicke area for patients who have tumors close to those speech areas in the so-called dominant part of their brain, the part that controls speech. So this is a lot to take in. It's just to give you an idea of what I'll be talking about further as we get along. In terms of symptoms, this is how these symptoms come to bear based on where tumors are in relationship to structures in the brain. So let's move on to a discussion about symptoms. And this is probably the most practical part of the talk really for you, is to understand if you or someone you know has symptoms of this type, to not ignore them, to seek attention for this, because you really can't underestimate how symptomatic patients can become without even being aware that they're becoming that way, because after all, their brain is affected. So if someone close to them can recognize it, it can make a big difference. So let's look at this wonderful schematic from the American Brain Tumor Association. It really kind of summarizes the important functions of the brain, the frontal lobe, the parietal lobe, the occipital lobe, the temporal lobe, and the cerebellum. And we'll just walk through what these functions are. Most of you have probably heard of these functions already in terms of where they're located in the brain. The frontal lobes, you've heard of people being frontal or released. They may have differences in different behaviors or moods, or their thought processes might be affected. Very commonly after head trauma, that will occur. So the frontal lobes are really about sort of self-regulation and behaving more or less, with a reasonable approach to your interactions with others, and those sort of things can really be affected by frontal lobe tumors. Sometimes people get irritable, they start doing things that they weren't doing before and acting differently. So those are sort of things to be aware of. And then at the back of the frontal lobe is that motor strip we already talked about. And directly behind that, the sensory strip. So the sensory motor, there's a sulci right in the middle that separates those two, called the central sulcus. And that is kind of the delineation between the frontal lobe and the parietal lobe. So the parietal lobe is, as we talked about, sensory. It's integrating all the sensory information that we get from the world. The motor, the touch, the vision, other senses that come in get integrated and understood, if you would, in that part of the brain. So spatial is one of the most important functions of that part of the brain, knowing where you are in space, knowing which way to turn when you're driving, understanding where things are as you're moving in the world. So those sort of things are really encoded in the parietal lobe. The occipital lobe is really vision, how you see the world. Do you see the world? So it's all directly encoded from the eyes all the way back to the occipital lobe. And then we get to the temporal lobe, which is again important in regulating behavior, but really important in terms of memory and putting together memory and vision and other important, higher functions together and regulating emotion. You may have heard of the amygdala. This is one of the parts of the brain that kind of drives sort of basic behaviors, that those are really encoded in the temporal lobe. And the hippocampus, which is very important for memory, is in the temporal lobe. It also is important in terms of seizure control. So these are all the different important structures in the brain. And the left-right or dominant, non-dominant understanding is really something that, you know, as a layperson or even in medicine, people may not necessarily be aware of, that your speech centers are really predominantly on one side of the brain. So in most right-handed people, your language is going to be on the left side. So it's really important to understand that. And a tumor that's on the left side will affect your speech potentially, whereas on the right side, it may not have any effect on your speech. And so those are the concepts behind dominant versus non-dominant hemispheres. So this information is all available through the American Brain Tumor Association. I've listed their contact information here. They're a great resource for people who are interested in learning more about brain tumors. So I won't show you very many real brain pictures because I don't know how much you want to see of the real brain, but these are actually fixed brain. So this shows the different, so the anatomy of the frontal lobes in the front here. This is the central sulcus. It goes between the two hemispheres in the midline. And then this is looking at the side of the brain. So you see the frontal lobe folds, you see the superior temporal gyrus, middle temporal gyrus, inferior temporal gyrus, all these structures that are just standard in all of our brains. They look exactly the same. And these gyri are really, you know, reproducible from brain to brain, so it helps us neurosurgeons find our way around. This is the midline view, so we're looking inside the brain in the fluid chamber of the brain called the ventricle. This sulcus here really helps you see the occipital lobe very clearly. So, and the cerebellum that controls our balance is way back here. So this is all I'm going to show you in terms of real brain pictures, but we'll look at some MRIs of real brains together. And I just bring back this sort of schematic to remind you of the different important functions of the different parts of the brain as we talk about further. So let's talk about symptoms. This list is by no ways exhaustive, but I think, you know, for us to just really emphasize the importance of paying attention to symptoms like this. Certainly a seizure can be hard to miss, but new headaches in someone who really doesn't have headaches, it's not something you should ignore. If you have new weakness or numbness in your body, maybe confused, have a hard time doing things that you normally were able to do, balance a checkbook or even dial a phone or have a conversation with someone can be affected. Speech deficits are usually pretty well noticed. Others notice that you can't get the words out, or your speech sounds garbled, or the speech just doesn't make sense. The words come out and they don't make sense. All these are obviously very critical symptoms that need immediate medical attention, but there may be some more subtle symptoms like your gait's unsteady, clumsiness, some memory loss, some personality changes or cognitive decline. And obviously, you know, the blurred vision or double vision, those are really can be signs of increased pressure inside the head, as can nausea and vomiting. So when it gets significant enough, that could be a later sign. So this list is certainly a very broad list, but I think it's an important one to keep in mind. So I'm going to just show you some examples now of meningiomas. So this is a young patient with a small meningioma. It's not particularly big. It's located right here on this MRI, and the central part of it is dark, and the lining on the outside that lights up, that's the soft part of the tumor. And that's the central part is dark because it's calcium bone inside the tumor. Meningiomas frequently get calcified. And the symptoms she had were basically headache and symptoms on the left side of her face, which is where this tumor is on the left side. And it was affecting the nerve at the base of the middle fossa here, which is the trigeminal nerve that innervates the face. And that's why her symptoms were occurring. And she got a scan and discovered this. Unfortunately, it was reasonably straightforward and took it out, and she did well with basically resolution of all her symptoms. Now, this one is a little bit different story, a bigger tumor, certainly. And as you can see, it's compressing the brain around it. The folds of the brain, you can see very clearly on the opposite side. You can't make them out on the side where the tumor is. And if you remember, we talked about the occipital lobe controlling vision, the parietal lobe controlling sensation and coordination of the limbs. So she was having a hard time moving the left leg and seeing on the left side. And that was really clearly, obviously, due to this mass. Unfortunately, we were able to remove it safely. She did beautifully. Her vision improved, her strength and leg strength and coordination improved, and she made a wonderful recovery. So these tumors, although they look, quite large and serious, are, again, vast majority benign and can be safely removed. This is another patient with a large meningioma. This one, as you can see, compresses on the front of the head. So it's compressing the frontal lobes. It's also compressing onto the fiber tract that runs between the frontal lobes called the corpus callosum. So this patient, really the fluid chambers are totally collapsed because of this tumor. And again, slow onset, gradual symptoms, eventually kind of to the point where, the straw that broke the camel's back, the symptoms become really, you can't ignore them and they have to be addressed. So it's, this patient actually underwent surgery and did recover most of those functions. Fortunately, we caught it in a good time span to get reversal of those symptoms she was having, and the fluid chambers opened up again and the brain collapses back into the space where the tumor had been, and the functions recover. I mean, it can take weeks or months, but it is fortunately a benign tumor that we can treat very effectively. So let's move on from meningiomas to pituitary tumors now. So these tumors are really diverse. They do cause kind of a standard set of symptoms, though. So one of the most important things that, or most common things that patients will complain about is headache or pressure behind the eyes. And that really is related to the size of the tumor, because these tumors can grow slowly again without causing symptoms until they get to a size where they finally do cause symptoms. And so headache, pressure behind the eyes, and then of course visual loss because of the pressure on the optic nerves. And in particular, it's the vision out here with the so-called temporal visual fields that's on the side of the visual field. If you held your hands up on either side of your head, those are your temporal visual fields. So they can't see them. They might have a car accident. Several patients I've taken care of have had car accidents because they don't see. And so important to keep aware of those sort of symptoms. Double vision can also occur. Drooping of the eyelid can occur, and all those are related to compression on the structures around the pituitary that we talked about. The other thing that can occur is the effects on the pituitary gland itself. By compressing the gland, the gland stops working properly. So they may see decreased hormone production, and then these are the symptoms that can occur as a result: irregular menses, loss of energy, loss of libido, feeling cold, weight gain, excessive thirst, and urination. And those are usually later stages. So any of these symptoms can occur with a pituitary tumor. Now, the ones that actually produce hormones do lead to specific symptoms related to those hormones. So for prolactin secreting hormone, they make milk. It can happen in men just as well as women. For patients who have excess cortisol production due to ACTH, which is the adrenocortico stimulating hormone, that adrenal gland is producing too much cortisol, they will develop Cushing's disease, which is excess fat pads, weight gain, the stretch marks, muscle wasting in the legs, and an elevated glucose. And then finally, we have acromegaly, which is a condition where the hands and the feet will get enlarged. Some people will say, my rings don't fit, my shoes don't fit anymore. Their facial features will become coarsened, enlarged nose or brow, and they'll notice skin tags around the neck. And these are all signs of excess production of growth hormone. In fact, my husband diagnosed a high school friend of his with this condition, and it's really common that people don't notice these changes because they're so gradual, and it's only when someone who hasn't seen them for a number of years sees them and says, oh, there's something changed and something going on, you need to get attention, and they get diagnosed. So I just want to mention one other form of important pituitary tumor that people are not necessarily aware of, which is this condition called apoplexy, where a pituitary tumor grows to a size that it can no longer sustain itself, its blood supply can be affected, and it can actually die. And parts of that tumor, when they die, they bleed into themselves. So that sort of tumor, pituitary tumor, is called a hemorrhagic pituitary tumor, meaning it bleeds into itself. And that can cause a condition called apoplexy, which is a sudden severe headache, loss of vision or double vision or drooping eyelid. And unfortunately, this patient had many of those symptoms: severe headache, nausea, vomiting, drooping eyelid, blurred vision. And fortunately, was able to undergo treatment and get this under control. But again, it has to be recognized and attention sought immediately. This is considered a neurosurgical emergency. And then finally, glial tumors, you'll notice the list is exactly the same as meningiomas, because really these symptoms all depend on where is the tumor located. It can affect any part of the brain. It doesn't necessarily occur in one place more than the other, maybe frontal lobes more often in this case, but meningiomas can occur anywhere. So when we look at a patient with a glial tumor, one thing we often see is that as this example shows, the tumor goes all the way to the lining of the fluid chamber of the brain right here. This is really common, and again, this tumor is in the frontal lobe, if you remember our diagram of the different lobes of the brain. So this is the front of the head, this is the back of the head, and this thing, you can see all of the irregular tissue in it. That's a very typical appearance for a glioblastoma. And they do occur in the frontal lobes, and they sometimes occur in both frontal lobes, and they cause what's called a butterfly glioma because they go into both sides. You can see the brain swelling around it. This is a really aggressive tumor, and you can see all the compression on the normal folds of the brain. So, this patient unfortunately presented with severe headaches. She was confused. There were personality changes and decline in her cognitive function. She really could not function. And the good news is immediately after surgery, she was able to function a lot better. She was able to communicate better, control her emotions, and had control of her headache. So, and of course, this is a tumor that you don't just treat with surgery. You have to do further treatments such as radiation, chemotherapy, because it is a malignant tumor, unfortunately. So the difference, of course, with meningioma and pituitary adenoma and glioblastoma is that this particular tumor, you're not done. You need further treatments after surgery is done. So let's talk now about the treatment options and really what I think are important things to keep in mind as we consider what are the latest technologies that we can use in treating brain tumors. And, we have come a long way. The picture on the left shows the pituitary tumor resection back in the early 1900s when it was first developed. It's a beautiful drawing from Max Brodel, going underneath the lip to get to the pituitary gland at the top of the nose. We don't use that approach anymore. Now it's, again, like I mentioned, the transsphenoidal through the nose, through the sphenoid sinus to the pituitary. And, in the 1950s, we introduced the microscope was introduced, and in the 1990s, the endoscope was introduced. So, the technology keeps improving for visualization. And this is a perfect example of how far we've come in less than 100 years. So the techniques that I really want to focus on are these three really important, valuable techniques and tools we have to improve surgical resection. So number one is the navigation. When we can take images from an MRI or a CT and register them to the head and know where we are exactly in space during surgery, that's a game changer. And that has come about in the last 20 years. You can't rely upon it. You still have to know your anatomy and know how to do the surgery exceptionally well, but the navigation is just a tool on top of those skills. Number two is the intraoperative MRI, and that is a technology that's available at Cottage and is really another game changer when it comes to particular types of tumors. And the third is electrocorticography, which is measuring the brain waves during surgery, which helps to guide you and identify when it's safe to remove a part of the brain or it's not safe. So these different techniques, the continuous monitoring allows, which I use in almost every brain tumor surgery, allows for continual recording to tell us how we're doing in terms of brain function, both motor and sensory. And then the bipolar cortical stimulation is really more of an active identifying specific parts of the brain that we need to identify if they're parts that we can remove or not safely. So we'll talk about those. This is an image that just shows you the navigation system that we use called the Brain Lab. The eyes are up here. There's a star-shaped attachment that goes on the head frame when the patient's head is pinned, and that allows us to register images to their head. And then we have these additional screens in the room that allow us to see the planes, the three different planes, and reconstructions of those images as well. So this is an example of what we might see in a brain lab scan. We can see the fiber tracts, we can see the tumor, we can see the safest trajectory to that tumor, and then we can see cross sections of that head on the screen while we're operating. This is another example of that. So this is one axial image. This is an image down the midline with the patient's nose here. You can see, and then the coronal, and you can see where the mass is and all the fiber tracts around it and what's the safest trajectory to getting there. The three-dimensional image up here in the corner is a really cool image to use for patients who have tumors on the outside of their head, particularly meningiomas, so you can make sure to preserve important veins on the surface of the brain and know exactly where they are. This is just another tool using Brain Lab where you can attach the star to the microscope, and then during surgery, you can actually superimpose the fiber tracts on the field that you're actually looking at. And that's a cool technology that's just been developed in the last few years. And I just want to mention, not every surgery can be done open, of course, or with an endoscope. Sometimes because the location is a deep part of the brain, like this one in the thalamus or the brainstem, you just can't remove this tumor. So what you can do is take a biopsy, and that's where we again use that same navigation system, and we target the tumor and take a piece of tissue, or we drain the fluid, like this dark area in the middle of the tumor, to maybe relieve some of the symptoms. So this is an important technology, not just for open surgery, but also for this sort of biopsies. The intraoperative MRI is a game changer when it comes to these two diagnoses: large pituitary tumors, really huge help for those, because when you're operating down either with an endoscope or a microscope, you can imagine there's a trajectory that's going into the nose, to the sphenoid, and you have a very narrow field of view. So if you want to look to the sides or you want to look way up, it's hard to see sometimes. So I think this intraoperative MRI is an enormous aid to really visualizing and making sure the tumor is gone. The glial tumors, in particular, the low-grade ones, sometimes it's hard to tell a normal brain from tumor in the low-grade tumors. So if you can image during surgery, you can actually distinguish on an MRI what part of the low-grade tumor may still be there. And that can change how much surgery you perform or how much more tissue you may need to take out. Big game changer for those particular types of tumors. In addition, they haven't shown it yet in studies, but it may make a difference as well for other tumors, skull-based tumors or large tumors where you may not be able to see around corners. So this is just a picture of the MRI that we have in our operating room. And you can see, for an example, the patient's head is going in here, and the radiologist is viewing images in the room to the side here, and the operating room is actually on the other side, and the patient is wheeled in, and scans are done immediately during the surgery, which really allows us to make a decision about whether or not further surgery is necessary. So this is just an example of what that looks like. A patient with a pituitary tumor right here, and the pituitary stalk coming down. And this is a tumor that actually goes into the cavernous sinus, the carotid artery on either side. So fortunately, with an intraoperative MRI, you can check and make sure you got tumor out of the cavernous sinus. If you have access to this adjacent structures like that, it can make a big difference in outcome and these tumor control. So this is a great tool for us. And then the electrocorticography, this is a little more complex and maybe not as intuitive as the navigation or the intraoperative MRI, but it's a really important tool. It allows us to map this important structures for motor, sensation, and speech. So this paper just gives an example of what that would look like. So the strip is this structure right here. You can use a 4-lead, 6-lead, 8-lead, however many leads you need, and you can stimulate the brain. And when you stimulate, you can identify the so-called phase reversal, which is the brain waves change in orientation directly around the central sulcus of the brain. And that allows you to identify, this is the motor strip, this is the sensory strip, and to ensure that you preserve those important functions that you're aiming to preserve. So these are, sort of technical notes and something that it takes a while to really get an understanding of and comfort with. And fortunately, we have a great team for neurophysiologists monitoring during these cases to really allow us to do these operations safely. And the other important mapping technique that we utilize is speech mapping. And now that has to be done awake. Obviously, you can't speak when you're asleep. So this is just an example of how a brain tumor in the left frontal lobe, which is close to speech, which is lighting up on a functional MRI, correlates to where speech is stimulated during a patient's awake speech mapping. And so that is a very important tool for us to use when we're trying to identify, can we safely remove a tumor? Yes, it's far away enough from the speech centers to allow that. So I just want to share with you one last example of a clinical case we've taken care of here recently, a patient with 2 tumors in the left frontal lobe, as shown here. And unfortunately, speech effects from those tumors. And we went ahead and did speech mapping awake, and he was great. He very cooperative patient, very fluent and able to communicate with us during the procedure. And you obviously have to have someone who can speak to do speech mapping. If they can't speak, you can't do speech mapping. But was able to identify the speech areas and mark them. So these little pieces of paper show us where speech is halted or slowed or delayed. So we know to stay away from those parts of the brain, which is Broca's area, and then remove the tumor both in front and then behind these two spots. So I try to show that here on these intraoperative images. And those are the only real brain images that I'll share with you today to show that point. So we've gone through a lot of information. I want to give a chance now for those who have questions to go ahead and ask them. We've talked about what sort of brain tumors there are, where they occur, how they can affect you, when to seek medical attention, who can provide the care that you need, and why I think Cottage has the resources and to really provide exceptional care. And one last slide is my son graduating from Stanford, so a little bit of humble bragging today. Thank you so much.
Thank you, Dr. Moayeri, for that wonderful presentation and great picture of your son as well. I think we're all into humble bragging from time to time, so thanks for sharing that. We'd like to open the room now for questions, so please put your questions in the box if you have any in the Q&A box, and we've got a couple that have come in already. This first one, if smell is associated with the frontal lobe, is taste as well?
Yeah, so oftentimes when smell is affected, people will describe that their sense of taste has changed or has gone away. So obviously smell and taste are intimately related and connected, and frontal lobe is where that function would reside, yes. It's the olfactory tract is the nerve that senses smell, but it innervates into the frontal lobe.
Great, thanks for that. Next one, why do meningiomas calcify?
Yeah, well, because I think they're arising directly next to the bone. You'll often see the bone reaction to that meningioma to thicken and form kind of spurs. And sometimes the meningioma will actually grow right through the bone, through the skull, and actually come out of the skull and be under the scalp. So there's an intimate relationship between meningiomas and bone. And sometimes the bone will be in the meningioma, and sometimes the meningioma will be in the bone. Why exactly any tumor actually can calcify? The main criteria, I think, for calcification is that it's been there a long time. So, even benign tumors that are not meningiomas can get calcified.
Great, thank you so much for that. Next question we have here is, how would I know if I have a brain tumor?
Yeah, I was afraid someone would ask that. So I would say you won't know. You won't know. You would really, if you have a suspicion that you're having some of these symptoms we talked about, the best thing to do is schedule an appointment with your primary care doctor, tell them what you're experiencing, and I would say 9 times out of 10, they're going to get an imaging study because, nobody wants to miss a brain tumor. And honestly, there's so much happening now with people just having routine scans, right? They're going in and getting an MRI of the brain or the body and finding these incidental small tumors. And then, the good news is now you know about it, you can monitor it. It's always easier to take it out when it's smaller than when it's bigger, right? So those sort of things come to your advantage. And there's many, many times people have an accident or something else, and they get a scan for some reason and just happen to find a tumor. So there's many, many ways for finding these tumors now. But I certainly, if you're having symptoms, no question, you should, seek medical attention and get imaging.
Great, thanks so much for that. Can pituitary tumors be genetic?
Yeah, there are a very small subset of pituitary tumors that are genetic. For the most part, they are not. They are sporadic. They occur, no one else in the family has ever had one. So I'd say the vast majority are not genetic.
A lot of people really just coming in to say excellent presentation, really clear and succinct. So wanted to pass
Thank
that
you.
along to you, and a couple more questions coming in. Have you seen any research about stem cell transplants and how they can help with brain cancer?
So right now, the leading edge, I think, for brain cancer is with T-cell therapy, immunotherapy. It's really been a game changer in other forms of cancer, and is hopefully going to be a game changer in malignant brain tumors, because we haven't significantly impacted life expectancy with malignant brain tumors since I've been practicing. It's still pretty dismal. So I would say, brain transplantation is great for disorders like, degenerative disorders, stroke disorders, where you need new cells to come in and take the place of the cells that have been lost. But we have the opposite problem with the brain tumor. We have too many cells and we want to reduce those cells. So the best technique to try to reduce those cells is to get the body to recognize them as foreign and to get rid of them. So that's where immunotherapy is really effective.
Thank you so much for that answer, and really want to thank you, Dr. Moayeri, for all of your time today. For all the folks watching, just want to let you know that we are recording this Zoom, and we will be sending out an email to everyone most likely later next week with a link to be able to view it. Dr. Moayeri's office is located at 2410 Fletcher Avenue in Santa Barbara, and you can contact her office at 805-770-9186. A brief survey will appear after this webinar closes, and we'd really love to hear your thoughts. Thanks again for joining us, and have a happy and healthy rest of your day.